Welcome to the Cheer Athlete. Today we're going to talk about the knee. And if you've been listening to the past couple of podcasts and perhaps you joined the balance webinar, you may have noticed I've been talking a lot about balance. And I just recently did an ankle masterclass that is live and up. And I talked a lot about the hip and the ankle, but I didn't touch really on the knee. So we're going to dive a little bit more into the knee and how that can affect balance and mobility and how it can affect you in cheerleading, and maybe not from an injury perspective. But I'm going to start with how do I evaluate and treat, or how do I evaluate and assess what's going on with the knee? Because people are coming to see me in the clinic, they're coming for an injury. And if they work with me outside, I do the same process, but I'm not necessarily treating them for an injury. So the assessment and the movement screen, which I talk about all the time, is relatively the same. And then in the evaluation, it gets a little bit deeper and more hands-on. So if you don't know me, I'm Laura Turner, and this is I'm passionate about trying to help cheerleaders and their parents and coaches keep cheerleaders on the mat, keep them progressing, and keep them healthy and safe so that they can continue to make strides in their cheer career. And so in this recent balance webinar and the ankle mobility, or the ankle masterclass, I talked a lot about how the ankle and the hip connect and how the core will connect to balance. But we didn't talk about the knee. So the knee in general, it's a hinge joint and it moves forward and back. There is a little bit of rotational component to it as well. It doesn't have a whole lot of side to side. So I talk everything. We're looking to get three dimensions of motion, three directions of motion in most joints. We want forward and back, like up and down, or we want out to the side and in, and we want a rotation. In the knee, we don't get a lot of side to side. The side to side, if your knee goes in and there's more of a torque in the knee that is kind of pushing more on either the foot goes out and the knee goes in, or vice versa, that can create some more strain through the ligaments and the joint in itself. So we don't try to create a lot of movement in that direction, but we want some rotation. We want the biggest motions are knee flexion and extension, which is bending and straightening your knee. In order to get that, you need to have that, we call it a screw hole mechanism, for the knee to unlock and to then straighten and lock, and it needs to rotate. Now, there are a lot of muscles around that affect the knee, and people are always surprised. They're like, oh, my knee hurts right here in the front. Okay, so in the front of the knee, we have bones. We have your tibia, we have your which is your shin bone, we have your femur, which is your thigh bone, and on the outside we have your fibula, which is the long bone that creates your outside ankle. So those comprise the knee joint. And then you have your patella, your kneecap. And there are the muscles in the front of the leg, your quadriceps. They attach, there's four quadricep muscles. One of them starts at the hip, the other one starts just a little bit lower, and all four of them attach into a common tendon. We have quad tendon and the patella tendon, kind of is one tendon that rides over the other and attaches into the tibial tuberosity, the point on the tibia. So people are always surprised when they come in to see me. They're like, well, no, it hurts here, but I also palpate and see what are the outside muscles are doing. You have your glutes there's three glute muscles that attach into the iliotibial band. You have a tensor fascia lata. I don't want to make this an anatomy lesson that can get boring, but suffice to say, there's about four muscles that would attach into that IT band that come down and attach into the fibula head that affect how that knee moves and rotates. And then you have your adductors on the inside of your knee, along with your sartorius, which comes from the hip and crosses the knee. That's just the front and the sides. Then we get into the back. You have your hamstrings, one of which, the adductor magnus, that kind of acts like a hamstring at times. They consider it the fourth hamstring. That's one of the inner thigh muscles, kind of closer to the knee. And then your calf muscles. So your hamstring muscles attach below the knee, and your calf muscles attach above the knee, your gastroc. All of them have to be working at just the right time, just the right speed, and just the right mobility in order to have good mobility at your knee. Our knee is meant to be a stable joint with our ligaments that are inside, your ACL, your MCL. they're and the lateral collateral and the posterior cruciate, and then your meniscus, that all provides stability into that joint and cushioning so that it can function and move right. One other key muscle I forgot, the popliteus, which is right behind the knee, and it's a tiny little muscle that goes from one side of the femur to the other side of the tibia, and that is actually what controls that screw hole mechanism and that unlocking and locking and initiates movement. So that has attachments into the meniscus. And if things aren't moving right, you're going to tweak something. ACL injuries usually happen from a traumatic injury. They're not generally degenerative over time. If you come down out of a stunt and you land with your leg hyperextended, or if you land a jump and you hyperextend and twist, tumbling pass, same thing. If you kind of just land wrong, your foot pivots the wrong way, that could create a strain through that ACL and potentially create an injury there. I think there are a lot of ACL injuries that occur. I see, all the videos online of cheerleaders wearing derotational braces to, help control that stability. But I don't know that that's like the number one injury. Ankle sprains and concussions are the two main injuries. And an ankle sprain, if you don't have the stability or you don't have the mobility in your ankle, then that's going to come up the chain and create a limitation in movement at the knee, and create a stability problem at the knee. Conversely, at the hip, because again, you have quad muscles, you have hamstring muscles, you have glute muscles, the adductors, they all catch at both the hip and the knee. And so if your hip isn't strong enough to control how the knee moves in that rotational movement and that flexion extension, then you're not going to have that stability down at the knee. So we need mobility in the ankle, and we need mobility in the hip. We need stability in the knee joint. So when someone comes to see me, I see a lot of patellofemoral pain. So pain in the front of the knee, hurts with jumping. It's better with rest. It can be associated with an Osgood-Schlatters, but basically that pain in the front of the knee, I'm going to look at them the same as I'm going to look at an ACL with a few different tests. So the first thing I always want to know when someone comes to see me is, how did it happen? Is there a recurrent problem? Has this happened over time? Has it gotten worse? What does it feel like? Did you actually have a traumatic event? Is it sharp pain, dull pain, toothache pain? Is it nerve-like? Those are all questions that I'm looking to get answers for, because that will tell me a lot about what's going on with your knee. You and your history will give me so much information to be able to help and know where I need to look and guide your treatment. So we're gonna talk about your history. I want to know your medical history. If you sprained your ankle in the past, that's really important for you to tell your therapist. If you've had a labral injury, same thing. So anything that's going to affect above and below the knee, that's definitely going to be important to look at. If you are an older client coming to look at me, I might look at, have you had surgeries? And this can be a C-section or a gallbladder surgery. Any surgeries I want to know about, because scars have a way of kind of creating altered movement patterns. So we look at your history, we look at how you injured it. What does it feel like? Is it getting better or worse? And what type of things aggravate it? Do you have pain going up and down stairs? Do you just have pain when you land a jump, or does it happen on takeoff? And the same thing with tumbling. And, does it wake you up at night? So looking at when do you notice it? These are all things that, if you're going in to get treatment, these are things I would have in the back of your mind that your therapist should know, because the limitations and when it bothers you, it all in cheerleading for sure, and out of cheerleading, those are all important. And those are all things that will help you get better with. So from there, once I get your history and know, what your background is and what the injury was, then I start to get into my physical assessment. I always start with a check-in to look and see, are you centered? Looking to see, do you have more pressure on the front of your foot or the back of the foot? More pressure on the outside or the inside? More pressure on the right or the left? And inevitably, so that's a key. We went through that in the ankle masterclass, and knowing where your foot position is, because ideally we want to have 3 points of contact between the big toe, the little toe, and the heel. And it should be even, and your center mass should fall smack dab in the middle of between your feet. So if you have pain, you might be shifting off to one side, or maybe you're shifting more onto that side and you need to actually unload it. And so knowing where your body is in space can help me to know, what are you doing to help to compensate it? And it lets me know that you're kind of starting to tune into what you're feeling and what it feels like to move. From there, I'm going to look at your posture. I always tell people they're always like, oh, I got really bad posture. And I'm like, listen, I'm going to pick you apart no matter what. I'm going to find something because nobody is completely symmetrical. We aim for that symmetry. We try to get symmetry, but nobody is really completely symmetrical. So there's going to be things that are off. The things that I want to look at is it glaringly off? Is there a big difference in how your hips sit? What does your back posture look like? If you go back and listen to the podcast I did with Chase Cavaliere, we talked a lot about, can you move that pelvis and get that into a neutral position? Do you have more of a sway back, or do you kind of tuck your butt under? Because that, if you're resting in that position, it may be harder for you to get out of that position. I look and see, are you rotated? Look what your shoulder blades are doing. Are your knees hyperextending, or are you resting with them bent? Then I get down and look at your ankles and see, where are your ankles and your rear foot? What's that doing? The posture is pretty much the easy part. And the next, I look at how does the pelvis move, and we isolate movements. Can you tip it forward and back? Can you shift it side to side? Can you move? If you bend one knee and you let the hip drop down, the other hip should go up, and they should be relatively equal side to side. And then rotation, and can you isolate rotating at your pelvis? Now, I like to do whole body assessments, but I have limited time usually in the clinic. So I usually, if I'm doing a lower body, that's where I'll start as far as mobility. Pelvis tells me a lot about how you walk and where your limitations are. I'm not looking, I care if you have pain, but I don't really care if you have pain in that moment, because I'm just looking to see, can you do it? Can't you do it? And are you struggling through it? And which way is easier? So the pelvis mimics what your foot does when you're walking. So the knee joint, again, that's going to tell us a lot about what's happening at the knee, because it does the foot, the ankle, and the knee. The foot, the ankle, the knee, and the hip have to move all in conjunction and smoothly to be able to function normally. Then we get into a gross movement screen. And this is what, we talk about, either the FMS or the SFMA. And I take bits and pieces of it because looking at gross motor movement, and the SFMA looks a lot more at mobility, looks more at a medical cause and is there pain. So usually in the clinic, that's what I do. If I'm working with you outside the clinic, I'm going to do an FMS. Now, what's the difference? There's a little bit more strength work. I look at a push-up. I look at rotary stability. We have those components worked in to SFMA, but it breaks it. There's more detail in there. I'm going to look at, can you touch your toes? Can you lean backwards? Can you twist? Can you stand on one leg? Can you squat? And can you get there with good form without pain? And then can you get down onto your knee? At this point, if it's looking like it's an overuse, I might not have you stay down on your knee very long. I will also look at your ankle mobility. We'll come up, we'll get on the table, look at, different, whatever I saw standing, I'm going to do some different mobility tests on the table to see, is it, if you can't touch your toes, is it because you don't have the strength or you don't have the motion? And what is it? Is it from your legs or is it from your back? Because bending forward to touch your toes will stretch your hamstrings and your lower back and all of your back muscles along up the chain up into your head and your neck and the whole back of your leg. So we need to know, is it just the back? Is it just the legs? Is it a combination? Is it a strength issue or is it a mobility issue? This is all the things that we break down as we go. Bear with I forgot to shut off my portal there. It'll ring for a second. From there, we are going to, so after I've looked at your mobility on the table and, is it a control factor and a stability or is it a mobility issue? From there, I will then get into some special tests. And for an overuse, some of that's palpation, poking at the area that's sore. For an ACL, if I'm suspecting that you had a traumatic injury and that there's some instability there, we're going to do different tests. Now, having had an ACL injury, acutely on the mountain, it is not a fun test because it hurts, right? And I don't, I try to go cautious, but I'm looking for that laxity. I'm looking, does it hurt when we do the shift, when we look at all the different motions and muscles. We don't like to push through pain. No therapist likes to push through pain. Sometimes we have to see, can you do it? And does it get better with repetition, or does it get worse? In which case we have to backpedal a little bit. So once we've ruled out ligament injury, we determine that it's more of an overuse and like a jumper's leg. We're going to get in and palpate, see what's tight. Maybe it's your hamstrings, maybe it's your quads, maybe it's the side of your muscles. And that's more that tension you feel. You can tell if there's restriction in a muscle when you poke at it. If you just rub your hand down your thigh, you can tell if there's different areas that feel like it's restricted. Doesn't necessarily mean that it's tender. Tender doesn't always mean there's dysfunction, but that tightness means there's some dysfunction there. So telling if something is tight will tell me there's probably some dysfunction. We're going to muscle test there. And then I get into some comparative muscle testing to see if your quad is actually strong and tight compared to your glutes, which may be weak and tight. So the tight muscles are the ones that we're going to correct. We're going to loosen up and stretch or massage the ones that are strong and overworked, in this case, the quads, because we've done our testing, and then stabilize at the glutes. So the home program from there, and I just saw somebody today with this, the quads, we're going to stretch, and then we're going to strengthen the glutes. Now, if you have pain with stretching, I might say use a roller and foam roll, because you're in control of that. You can massage it yourself. Anything to just get the tone in that quad to quiet down. And right away, in conjunction with that, you're going to do some glute bridges or potentially some split squats. It all depends on where you're at and where you're starting. Maybe some roll to elbow for a Turkish get up. All of that's going to stabilize at the glute and getting the glute active, telling the quads to quiet down. This is where tuning into your body comes in handy, because inevitably, if you compensate, you're going to feel it in a different location. So if you're trying to do work to, say you're doing a squat or you're doing a deadlift and you're feeling more work in the front of your knee, then you're likely using your front of your knee and too much. So that would be too hard of an exercise and we're going to regress it. There's a lot of different exercises that I'll use, and it all depends on where someone's at. I like to do a lot of weight shifting on stairs. I think step up exercises, forward, sideways, and curtsy are great at getting your glutes engaged, but sometimes the knee just doesn't handle it. And so we have to teach how to weight shift onto that leg to be able to get good mobility through the foot, get some load into the upper thigh to create that stability and take the pressure off the knee. It can take a few times for that to feel better, but the more we work at it and the more we kind of train good movement, get the tibia moving good, get your femur moving good, create good rotation with that flexion extension, that all starts to get better. So we sometimes think the knee is just an easy joint. I do. I used to think when I was in school, I was like, wow, this is boring. We just do quad sets and heel slides and ankle pumps. And that's all you get after a knee injury. And that's no longer. We don't do that. We look at, how do you move? Can you get it moving? The knee is a crucial point of stability between the hip and the ankle. And so we need the hip and the ankle to move well. And that's what doing, a quad stretch and some glute bridges would come in. And again, there are so many exercises out there. You can pull up Instagram, you can find a slew of exercises for the knee. And that's okay. You can try them, because a lot of, if they don't hurt and you can do them with good form, like the person that's showing you, then go for it and try it and see if it helps. If you're compensating, if you're, if I'm showing you a single leg squat and your knee, you try it and your knee's just wobbling all over the place or going in and you can't do it because it hurts, then that's too hard for you. We need to regress it a little and figure out what feels better. And that will all depend on where you're at. Single leg squat is a great exercise to strengthen the hip and create some stability around the knee as well. But if you don't have the control to begin with, you may need to do something to loosen the hip up, loosen the ankle up, so that you can create better motion in there. And then you'll build from there. Frequently in physical therapy, we're like, do 3 sets of 10. And that's the end all be all, because we want to build that strength. But sometimes if we need stability, we actually need to not do as many reps. We work it to fatigue. We work to that. In neurokinetic therapy, we call it the neural edge. That you work until it just starts to fatigue, and then you stop. Because if you push through that fatigue factor, the brain starts to circuit and be like, nope, I'm going to trip this wire, and we're just going to make the other muscle continue to do the work over and over again. So you need to create mobility in your ankle, create mobility in your hip, knowing what's tension, what's tight, and what's overworked, or what's overworked and tight versus underworked and tight, and create that balance and symmetry in there. As a cheerleader or a parent or a coach listening to this, you don't need to do all that. That's what I do, and that's what other physical therapists do, is looking at that motion. But what is important for you to be aware of is pain is not normal. So that's the first sign. If it's something that is an ouch pain, we need to back off. We need to get it assessed. If it's fatigue, and you're just learning, you're starting to control emotion, and that, say they're working on a heel stretch and they're trying to get their flexibility in their hamstring. Well, if the front of the leg is cramping and getting tired and overworking, it's the hamstrings are then going to tighten up to pull down and stop the leg from going up. So work it to fatigue, and stop at that point. Like, don't keep pushing through, because over time that irritation will create injury. And we can avoid those overuse injuries by just listening to our body. Now, cheerleaders, this doesn't mean that you get to bag out at doing your workouts. You need to do workouts. You need to do the work, but it is okay. Like, you got to start to learn. This feels like a nice stretch. This feels like it's working and the muscles are getting tired, and I'm a little shaky at the end, but it's okay. This is like, whoa, I've done 2 or 3 reps and like my leg is just shaking like a leaf. And that's when I need to stop. When we start to tune into our body, when you know where your feet are in space, when you know what it feels like to shift your weight, you can recognize better as to how, what is potential risk of injury versus what is normal movement. We talked just a little bit today. We talked about single leg squats. We talked glute bridges and Turkish get ups for glute strengthening after doing some mobility work in the quads. Again, limited conversation. There's a wide variety of exercises you can do, and you got to just explore what works for you. But the key takeaway that I want you to remember, the ankles need to have mobility. We need to do circles in big range of motion. We need to be able to drive. Our knee actually should be able to go past our toes, and not create pain in the knee or in the ankle. So if you've had an old ankle sprain, you don't have that flexion on the ankle, dorsiflexion, then your knee might not go forward and your talus doesn't move. So you might need a little work to improve that some. We also need mobility in the hip. It needs to go in, out, forward, back, and the hip doesn't need to go in and out and rotate as well. And if any of those are restricted because the joint is tight or because the muscles are tight, then that's going to affect what happens in the knee and maybe cause more overuse and more instability in the knee that tells the quad muscles and the leg to move in ways that it doesn't want to move because it's trying to move too much for lack of mobility at the hip and the ankle. Create stability into the knee. Squats, deadlifts, step ups, lunges if it doesn't hurt, and even just balancing on one knee are all precursors to getting some stability in that knee. And I've been back on a Turkish Get Up kick lately. I've got a lot of people doing that in the clinic because they need to get that roll. They need to get that hip extension and pushing. It's a great way to train the hip stabilizers and the hip mobility without putting a lot of strength through the knee joint. And it's just, we're not even getting up into that half kneeling position. If you don't know the Turkish Get Up, go Google it. There's a lot of videos out there that you can see it. I recommend looking at the Strongfirst version, or Kathy Dooley's version. She gives a wonderful explanation and gives you some compensations to use for that also. So check those out. I'll leave some links in the show notes. All right, that's a little bit about the knee. I hope that was helpful. You can always email me if you have questions. If you want help in doing a movement screen, if something is causing you pain, I'm going to refer you out. But if you want help in just looking at, how do you move, and are you moving well? Do you have the mobility that you need to be able to do the task that you want to be able to do? I do offer a movement screen, and you can find that in the show notes. And if you want to learn more about the ankle, go check out that masterclass that's up as well. Thank you for listening. I appreciate it. And I hope you have a wonderful week. And don't forget, when in doubt, breathe it out. Take life one step at a time. You can do anything that you put your mind to. And as my friend Drew Kelleher said, you're responsible for your own vibes. Let's go get the day.